We got 37 on. Welcome. This is Jeremy tells me I'm bad at counting. I think this is like our 7th lecture.
It says number 7 on the screen.
And so far it's been received with a lot of it's been received really well. We've had a lot of success, and so we're trying to keep this going as long as we can. Thanks for joining us. Jason has put together a really nice lecture on adolescent idiopathic scoliosis. It's a little bit of a turn from some of the topics we've been doing. Before we go through that, though, Jeremy's going to do a review of last week's topic, which if you guys weren't able to join for that, that was a trauma presentation, how pediatric patients present in a trauma setting, and looking at how their fractures are different from adults.
Yep, so we just try to keep the pediatric theme going for at least this week. So we just have some questions and just to review some of the topics that we touched on last week. So the first question is, how would you classify this physeal injury? Let me pull up the poll.
While you guys are looking at that, just if this is your first time joining us, if you haven't, however you found us, if the link was forwarded to you, if you haven't been getting our emails, just put your email in the chat and we will add you to our email list. That way you can get the comprehensive emails that have links to all of the prior lectures and PDFs.
And the results are coming in. Just orient yourself. This is the AP of the distal femur. This is the knee joint. Alrighty, gonna end it. So the majority of you guys got this question correct. It's a Salter 2 or Salter-Harris 2 fracture of the distal femur. And what that means is that the fracture energy went through the physis and then it exited up through into the metaphysis. And if you guys remember, a type 1 is completely through the physis. A type 2 is through the physis and then goes through the metaphysis. Type 3 goes through the physis and then exits through the epiphysis. A 4 passes through and so goes to the epiphysis, through the physis, and then into the metaphysis. And a 5 is completely crushed. One way to remember it is applying the word Salter to these. So type 1 is S for slipped, type 2 is A for above, type 3 is L for lower, type 4 is through, and type 5 is R for rammed. And then if you guys remember, Joe's way of remembering this is he remembers a type 2, the prefix is di, so it's through the diaphysis or going towards the diaphysis. And then 3, if you make the 3 with your fingers turned into the side, that's an E, and so E is for epiphysis. So that's a nice way to remember and distinguish between 2s and 3s. All right, next question is how would you name this fracture? And then a second part to it is, why does this fracture occur? So again, to orient yourself, this is CT cuts. This is a coronal view of the ankle, medial side, lateral side. And then this is a sagittal view of the ankle, with this being the anterior and then this being the posterior. So you can see this fracture coming through here. And it's at the anterolateral aspect of the distal tibia. So that's a tough question, but just wanted to include it to go over some points from this topic. Alrighty, let me just end it. So we got results kind of all over the board. So what you guys are looking at is a Ippolito fracture. So it's a fracture through the distal tibia at the anterolateral surface. And the reason why is it's because this area is the last of the physis of the distal tibia to close. So it's the weakest point, and it's caused by an external rotation force that is an avulsion through the AITFL, or the anterior inferior tibiofibular ligament. And so, like I said, it's due to this unique way of physis closure at the distal tibia, and it starts centrally, and then it goes anterior medial, posterior medial, and the last portion is the anterolateral or lateral surface. Just to go back, I didn't include any pictures, but you can exclude a triplane, because a triplane, it does have a component of a, again, this is a Salter-Harris 3 fracture of the distal tibia, because it's through the physis and then into the epiphysis. A triplane has a component of a Ippolito, so it does have a fracture through the epiphysis, but it also has another fracture line that goes through the metaphysis, and that is on a different plane as well. Another example, the or a unique physis closure is also in the elbow, and if you remember, that was a mnemonic crito is a way to remember the way that the distal humerus physes appear. So question number 3. What fracture type is this? And then what is your treatment? So while you're answering this, this is an AP of the elbow on the right and a lateral on the left.
Oh boy. What if we think there's not enough information?
I agree with that.
Alrighty, let's see what you guys put. So the majority you answered D, which was type 3 supracondylar fracture, and you thought that the treatment option would be close reduction percutaneous pinning with 3 lateral based pins. So we know it's a 3 because we have disruption of the anterior and posterior cortex, and if you remember, all the Gartland classifications of supracondylar fractures are extension types. So you can see that there's this extension deformity of the fragment here. We can cross off a type 2, which is it's hinging at the posterior cortex. We can cross off a B, which is a lateral condyle fracture, which is just a fracture through lateral condyle and going intra-articular. You could potentially choose answer C. And if you guys logged onto the Instagram account today, there's a post about which pins are the most biomechanically advantageous. And so out of this institution, Dr. Saberwal looked at this, and they found that if you diverge your pins, meaning you spread them out and have the tips of the pins going away from each other, that gives you the most biomechanical stability. In that study, they looked at use of 2 pins. And so out of the 2 pins, spreading out by 60 degrees was the most. And then they found that 3 pins was even better than any of the 2-pin combinations. However, if you do add a medial pin, any pins crossing over are going to be the most stable. However, if you start a pin on the medial side, you have to watch out for the ulnar nerve, and that could potentially give you an injury to that. So the best treatment and the most common is going to be your 3 laterally based pins. And a way to remember this is for type 2s, you usually do 2 pins, type 3s are 3 pins, and type 4s are 3 or 4 pins. And this is an image to show that diverging pattern of the pins. What are you going to say, Joe?
Well, I was going to ask Jeremy, for the students, how do you make the difference between, how do you determine the difference between a 3 and a 4? And is that, for you, would that make the difference between risking going medial?
Yeah, so you make the decision between a 3 and a 4 intraoperatively, and the 4s are more unstable and in multiple planes. And so in that case, you would either you would try 3 pins and see if you have enough stability, and then if you don't, then you might add a 4th pin from the medial side. And yes, you are risking a potential injury, but you just make a smaller incision. You can place a retractor in there to retract the nerve out of the way, and lower your risk of injury there. All right, and then the last question is what area can we accept the most amount of deformity in the body? So when you're going through this question, think of the location and also look at the ages of the patient. And I just realized now that I didn't include a bonus question. I messed up.
Damn.
I know. Alrighty.
All right, I got a bonus question. We'll have them type it into the chat.
All right. So, yeah, majority of you guys got this. So it's the proximal humerus in the sagittal plane in a 3-year-old. And I included this question to go over a bunch of different topics. So first, the areas that you can accept more deformity are going to be in your more active physes. So in the upper extremity, 80% of the growth is from the proximal humerus versus 20% of the distal humerus. And then in the lower extremity, most of your growth is coming from your distal femur, proximal tibia. And if you remember from last week, a way to remember your more active physes are thinking of a person sitting in a bathtub, and anything above the water is going to be a more active joint. So the distal femur, proximal tibia, proximal humerus, distal radius. So just think of that. In younger patients, they're going to have more time to remodel. So that's why, if you go back to the question, 3-year-old's going to be better than a 5-year-old just because they have 2 more years of additional growth. And then you're going to accept more deformity in the plane of motion of the joint that it's nearest to. So in the distal humerus, the elbow flexes and extends. So you're going to accept more deformity in the sagittal plane of the distal humerus. Same thing for the distal femur, because the knee flexes and extends. Same thing for the distal radius, because you flex and extend your wrist. So although in this question, the distal femur does grow about almost a centimeter per year, this is a 14-year-old. I didn't specify if it was a male or female, but this patient's almost done growing. So you're not going to get that much remodeling, rather than a 3-year-old has 10 plus years of additional growth and ability to remodel. Alrighty.
All right, bonus question. Type into the chat, White Russian or Moscow Mule.
Wow, that's easy for me. I'm going Moscow Mule.
Man, that was overwhelming.
Yeah.
I don't know what a White Russian is.
The dude, Big Lebowski, nothing?
Talking to me?
Thank you, Declan. Somebody with a little bit of love.
Alrighty. Chan, I'm going to stop sharing.
All right. I'm going to attempt to figure this out. I didn't accidentally share
So
my
it was
grocery
Mark.
shopping list, right?
It was Mark and Declan versus the world. And yep.
You guys see the slides?
Yeah, we don't see your face though.
Or you want to see my face? You already see my face. Anyway, my name is Jason. I'm one of the third years like Joe. I'm going to be talking about adolescent idiopathic scoliosis. All right. So it's kind of one of the bread and butter things that that we do in orthopedics as pediatric orthopedic surgeons. But really, what is adolescent idiopathic scoliosis? So if you just kind of break it down, adolescent is defined for these purposes as the ages of 10 to 18. Anything before that would be called something else. Anything after that would be called adult. Idiopathic, meaning we don't really know what the underlying cause is, no genetic factors, no no obvious cause, no structural causes for the spine to become deformed. And scoliosis is a generally accepted as a coronal deformity of the spine with greater than a 10-degree curve in the spine in that plane. While we generally think of the AIS as a coronal deformity, it is a complex deformity that includes sagittal deformity, coronal plane deformity, as well as axial deformity, which is essentially twisting of the spine on itself. Okay, and so it's and we'll get into how to measure spinal curves later in the lecture, but it's defined as greater than 10 degrees because anything after that you can basically positionally change your spine, and that's why they have to have that kind of lower limit. It's not just any type of curve. Like I mentioned, there are different kinds of scoliosis, and so what we're going to be talking about today is idiopathic, but there's infantile scoliosis. Essentially, basically, your the age cutoff for that is I think it's less than 4. And juvenile from that age to 10, and then adolescent, as we mentioned, 10 to 18. Congenital, due to something that they're born with. So either failure, so it's a failure to form essentially in the spine. So either failure of segmentation or failure of formation, and it's either less bone or fused bone. Neuromuscular is due to brain, spinal cord, and muscles. And so CP, Rett syndrome, SMA, muscular dystrophy, spina bifida, and polio. Okay. To go back to congenital, it can be associated with things like Bacterial Klippel-Feil disease and some very, very rare things like golden heart, oculoauricular vertebral syndrome, and Yarko-Levin syndrome. I don't know what those are, but they exist. Pathologic is something that can be caused by something like a tumor in the spine, causing it to grow in a weird way, like a osteoid osteoma or osteoblastoma. And positional, you can have the perception of a curve in the spine by leg length discrepancies. Imagine having one leg is considerably shorter than the other one. It causes you to stand in a different way and causes your body to compensate, giving a perceived curve in the spine. Okay. This is just, if I wasn't able to describe that well enough, an example and kind of a picture description of what congenital scoliosis is. You see cause like a change, a curve in the spine because either, how do you do this? Laser pointer. So either the vertebra didn't segment and you have a bunch of them that are fused together. You can have the whole vertebra fused like that, or you can have half of it, or you could have a combination, right? So you can have, or you can have hemivertebra, which is only half of a vertebra, or you can have fused hemivertebra or with a bar, okay? Just an example of what a neuromuscular scoliosis is, and kind of beyond the scope of this talk. So overall, AIS has anywhere between 0.5% and 5% in the general population. It's the most, AIS is the most common of all pediatric spinal deformities, with 80% of all scoliosis. And incidence of different size curves, 10 to 20 degrees is about 3%. Anything greater than 30 degrees is about 0.3%. There is a female predominance here. In curves greater than 10 degrees, the female to male ratio is about 4 to 1. And with curves that are greater than about 30 to 50 degrees, the ratio is about 10 to 1. And so, as the name implies, nobody really knows what the cause of AIS is. But there is a strong genetic component to it. They haven't really figured out what exactly the gene is, or if there is a gene. In monozygotic twins, there is a 92%, and in dizygotic twins, 36 to 63%, and up to 11% concordance in first degree relatives. Theories of why this happens that have not necessarily been proven are that
Jason,
proprioceptive. Yep.
Your audio seems to be breaking up a little bit. Do you know if there's any positional?
Is this better?
Yep.
Okay. I'm leaning into the computer now.
Okay.
So some theories are that there's proprioceptive dysfunction or maldevelopment in the central pattern generators, basically the genes that kind of create the spine, but nobody's really proven anything. And there's been seen that there's chromosomes that appear to play a role, but nothing has been identified as of yet. And so with regards to the progression of AIS, it's largely determined by curve magnitude and location and growth potential, okay? So with a curve that's greater than 25 degrees, this will likely progress. And so curve progression happens during growth. And so that's why it's very important to kind of understand how much growth potential is left, okay? So most curves that are under 50 degrees and in the thoracic spine and under 40 degrees in the lumbar spine will progress after skeletal maturity. But typically curves under these magnitudes will not progress after that. But obviously it's not like a blanket statement, it's just kind of in general, okay? And if the curve progresses and the curve gets worse, it can lead to lifestyle change, increased deformity, not only visually, but increase in pulmonary compromise. You can imagine like the lungs getting crunched to that side.
Can I just
kind of a, hello?
Yeah, I just want to add a point. So in general, thoracic curves are going to progress more likely than lumbar curves. And if you have a double curve, meaning a curve in both the thoracic and lumbar, or a cervical and thoracic, the double curves are going to be more likely to progress than a single curve.
Right. Yeah. So just kind of a brief overview of anatomy of the spine. In the cervical spine, you have 7 vertebrae with 8 cervical nerve roots. In the thoracic spine, you have 12 thoracic vertebrae with 12 nerve roots, and most of the motion is in the sagittal plane, so kind of like bending forward. You don't get a lot of twisting there. You don't get a lot of side-to-side movement. But you do have to consider the morphology of the vertebra when you're doing your surgery. If you're at different levels, you have to place your hardware at different levels, and you have to take into consideration the diameter of the pedicles. And generally, the pedicles are angulated cephalad, so keep basically kind of pointing up towards, or kind of pointed down towards the ground. In the lumbar spine, you have 5 vertebrae and 5 nerve roots, and the pedicles kind of angulate more towards the center and a little bit distally, and again, have variable pedicle diameters. Here's just kind of a slide that I pulled off of Ortho Bullets that kind of summarizes that. You can notice that in the thoracic spine, these the thoracic spinal vertebrae are different shapes compared to the lumbar spine. These kind of go a little bit more forward in terms in this plane, and so your screws will have to go in this way. And when you're in the lumbar spine, you have to remember to kind of angle in medially right here. And if you look on the lateral view, this is kind of it goes a little bit more straight, and here this one comes a little bit further, aims a little bit down like that. So kind of aims a little towards the floor. Again, just you don't have, this isn't super duper important, but this for this level, but just keep in mind how big the pedicles are. You can see that it varies from the cervical spine through to the lumbar spine. And this is just a demonstration of the change in angle relative to the midline plane of the vertebra. Really not anything that you need to memorize, but it's, unless you're going to become a spine surgeon, but something to take into consideration that you need to know. Okay.
Right. Can I add one more thing? So the size of those plays a role in when you're in the operating room, because you want to try to get the largest screw that you can to resist pullout. So knowing the relative size of the pedicles is important, but a lot of the times just these more senior level spine surgeons can just look at a pedicle and know relatively what size screw they're going to be putting in there. And Jason will probably be able to point out some examples in the future of the varying sizes of the pedicles as you go, but overall you want to try to get a larger screw if you can.
Right. Yeah, so I mean, kind of going back to this slide, like Jeremy was saying, if you're at, say, like T4, you kind of have to know that it's the smallest one, and if you go bigger, you might risk kind of blowing out of the pedicle, either, you know, out laterally or into the canal, which would be not great of a thing. And but you know that T1 is the larger in the upper spine, and so you can be a little bit more generous with your screw size. Okay. The general history of AIS is that it's most often painless, and unless it's like a very, very drastic curve, people won't really notice. The patients themselves won't really notice. They'll just kind of be part of them, and oftentimes it's noticed at school screening. I don't know if you guys remember when I was in middle school, they had us they had to screen us for scoliosis, had us kind of like bend over forward, and they kind of saw how straight our spines were. And I mean, I don't have scoliosis, but they would kind of recommend evaluation if they had any type of like obvious deformity there, or if you're kind of or just kind of noticed by family, they realize that, you know, you have a crooked spine. Okay, and it's important when you're going into patient rooms to take this history to understand a couple important points. So, how did they find it? Like, was it seen by the school nurse or was it seen by family, and the time frame of progression, because like mentioned earlier, the progression is highly timed to the kind of growth spurts of kids. The faster you're growing, the faster that you're going to progress, the more likely that you're going to progress. So that's really important. You need to ask about pain, or if they have any neurologic deficits. Typically, in scoliosis, it's like I mentioned, painless, and you shouldn't have neurologic deficits. And so you got to think of other things if you see those things like weakness, numbness, and tingling. You guys are all like advanced medical students, so you guys kind of know those things. Again, mention of growth spurts for girls, age of menarche; for guys, age of when they started having voice changes, because again, these are connected to growth. Always have to elicit family history, their own personal history of any genetic conditions, as well as family history of scoliosis and possibly genetic conditions that may cause a scoliosis, not necessarily AIS, but any type of deformity of the spine.
Jason,
Yep.
what's the name of that test that you mentioned that the nurses typically do in the school?
Oh yeah, we'll get to that, but it's called the Adams Forward Bend test.
And that one for the students is a very easy question to be asked when you're on your rotations and attending. They ask about the Adams Forward Bend, and I don't know if you're going to go into it, Jason, about like what is the
really briefly.
threshold.
If you want to talk about it right now, I'm happy to.
Oh, if you have a slide coming up on it, I just didn't know if we're going back to it. Keep going.
Yeah. So again, big emphasis here is on skeletal maturity. It's very important when you dictate the treatment and likelihood of progression. Curves progress during peak growth, and determination of peak growth is very key here. Okay, so peak growth velocity in females is about 1 year before menarche, and growth ends about 2 years post menarche in girls. It's a little bit more difficult in guys. Generally, you can make a rough estimate of when they begin their growth spurt, kind of when their voice starts changing, and you have like a year kind of bookending those about when you're growing. One way to look at the skeletal, look at the growth potential of males is by a pelvic X-ray in the hips. Forgot to put an X-ray of the hip, but the triradiate cartilage is is basically kind of like the physis of the pelvis, and they need to, and Joe's going to kill me for saying that, but kind of like that if you want to think of it very rudimentarily. But if you look at that and the triradiate cartilage is still open, that means they have substantial growth remaining. And you guys have learned about this in medical school, but Tanner staging based on secondary sexual characteristics, so breast growth, axillary hair growth, pubic hair growth, things like that. And Risser staging, which is kind of what you'll be asked about, which is based on the ossification of the iliac crest apophysis, and we'll touch on that in a little bit. And a new thing that's kind of coming into vogue recently is a Tanner Whitehouse staging, which is based on maturity and growth ossification of the hand in conjunction with the pelvis. But for right now, kind of pimp questions and things like that, research stage is kind of where it's at. Okay. So when we talk about the Risser staging, we're looking at the iliac crests. So kind of right here. And as you mature, this apophysis will start ossifying, coming from the front. And as you mature, it'll progress towards the posterior aspect, okay? And so Rissers 0, 1, and 2, at these stages, you're still relatively immature and still have significant growth. At 3, you still have a little bit left, but when you reach about 4 or 5, you're pretty much done growing, and that gives surgeons a lot of information about how they should treat you and how much potential for scoliotic progression there is. So when you are in the room doing your physical evaluation, things that you need to note and be actively looking for on inspection without even touching the patient, whether or not there are hairy patches kind of in the midline looking for like a spina bifida occulta, things like that, nevi, dimples, cafe au lait spots looking for neurofibromatosis, and things like that. Just make sure that, and don't write off the skin exam. You need to look for symmetry. Look at the shoulders, the waist, and if there's increased rib prominence on one side or the other, or if there's a very obvious truncal shift. Okay. Palpation, just kind of feel up and down the spine. In most people, you'll be able to feel the spinous processes and get a feel of kind of if there is a real curve or if there's not. Right? With the musculoskeletal exam, you need to take note of any deformities of the limbs, and if there's any discrepancies. Remember, we mentioned positional scoliosis. If you have one leg that's a lot shorter than the other one, it could cause a pelvic obliquity that causes a perceived asymmetry or scoliosis of the spine. Also, with like a cavus foot, you can have some sort of neurological deformity underlying that nobody's really noticed. You need to get a full neuro exam, make sure that they're strong, that they have good feeling, that there's no deficits, as well as and one thing to note in scoliosis is the abdominal reflexes. That to test for abdominal reflexes is kind of fun if you're into that kind of thing. But you tickle the abdomen on both sides of the midline, and you note that if they're symmetrical or not. It doesn't much matter if there is a reflex, and the reflex is kind of like a contraction, like you're getting tickled essentially. But if both sides can either have a contraction or both sides don't have a contraction, that would be symmetrical. But if you notice asymmetrical reactions, then that's something to key you in that there's something else going on in the spine that you might need to look more for. Okay. So we mentioned the Adams Ford bending test. Okay. And this is kind of where it's at. You have your patient remove the upper garment so that you have a view of the spine, and you have them bend over forward. You'll notice that if there are any prominences on one side, and that suggests that there is a curve on that side, you also have to notice, again, any rib prominences or things like that. There is I didn't include a picture of it, but there is a special tool that the school nurses will use. They'll place it on the midline of the spine and essentially measure the angulation of the asymmetry in the back. And there's cutoff that they would refer to someone else. It's not just, leaning over, oh man, you have a bump on your back or something like that, okay? And this also gives you a clue of where on the back, if you were looking on x-ray, where the curves would be. So if here you see that there's a bump kind of over the thoracic spine, you can kind of guess that the curve is going that way, okay? And we mentioned symmetry and asymmetry. Looking at the shoulders, if one is higher than the other one, okay? And you can look at bony prominences like the acromion, or you can look at the shoulder blade or the scapula, okay? To see if one's higher than the other one. Another one that's a little bit more subtle is whether or not they have a waist curve. You notice on this picture here, there's a little bit more of a crease here, so there's more of a waist on this side. And on here, on the right side here, there is it's more flat, okay? And you can look at the hips to get a nice feel for kind of any type of pelvic tilt or anything like that.
Jason, just going back to the Adams Ford bending test. So 7 degrees of that test equals about 20 degrees of coronal plane deformity. So,
yeah. So that's with that little goniometer that you can use to try and measure the angulation, where you're looking at the slope of the rib hump as compared to the pelvis. But it's a very, very non-quantifiable measure. Like it's very subjective to the point
it's a
where
speeding test.
Yeah, it's basically, if you can see a deformity, by the time you can see it, it's around 20 degrees as measured on an x-ray. The true radiographic deformity is close to 20 degrees by the time you can pick it up. And just to discuss this a little bit, the reason those ribs come out out the back like that and create prominence is because what Jason mentioned, this is not just a coronal plane deformity where you're simply taking the spine and bending it one way or the other. It's a multiplanar deformity that not only bends in the coronal but also twists. And so as the spine twists and bends, it's forcing those ribs more prominent on one side as the spinous processes rotate away from that side. So the rib prominence is always going to be on the concavity of the curve. As it bends away and rotates away, it draws the ribs into a posterior prominence.
Also, before we go on, can you go back to the Risser stage? And I don't know if it was discussed, but just the difference between, how do you decide between a 1 and a 2, 3 and a 4? Like, what percentage of the are you looking at?
I thought I had a picture of that. I guess not. I mean, essentially, you divide it into 4 quadrants.
Yeah.
Right. So 0 is none, 5 is fused, and the remainder are divided into quadrants.
Also, kind of like between the two, it's kind of subjective, but I mean, a lot of times, like when you're at like 2, that's kind of like I think that's kind of the major cutoff point. So like if you're about halfway, then you've still got some growth left. If not, then you're already on your way to skeletal maturity. Where were we? Okay, imaging. So generally what's going to happen when like a school nurse or your mom or something like that notices like a curve in the back, the child's going to be sent to the family practice. If they're very good to you, they'll order scoliosis films, and this is just a full-length standing P to A. We're used to shooting films from the front to the back, but this is a P to A film, and that allows us better imaging or better visualization of the spine. And you can imagine that the spine is in back, and you'd get a little bit less beam scatter if it's shooting from that, I think. And you get a lateral film to assess for sagittal balance, okay? For pre-op planning, we'll get spine films as well, but they'll be bending one way or the other, and we'll go into that. Advanced imaging such as MRI to look for spinal cord pathology is usually not needed if it's a stone cold AIS, 13-year-old girl with a right-sided curve. Usually not going to get that. But if you suspect that there's something more, like we mentioned, an atypical curve pattern, like a left curve, so like a levoscoliosis, or rapid progression, excessive kyphosis, so that's a sagittal plane deformity, any other structural abnormalities like we talked about, hemivertebra, bars, neurologic symptoms, so abnormal abdominal reflexes, we mentioned foot deformities, and like put asymmetric abdominal reflexes, kind of stuff like that. Things that aren't typical, then you would want to get an MRI because there could be spinal cord pathology, and you'd as the surgeon would need to know about that kind of stuff. Okay. And this is what scoliosis films look like. Just there over here on the left side of the screen is your regular PA. This is a lateral. This is a left bender. This is a right bender. Everything's flipped. Okay. So oh shoot, this slide's out in the wrong place. But how do we measure a curve? We measure it by measuring something called the Cobb angle. And this is basically finding the angle between a line that is parallel to the superior end plate. So this is the superior end plate here. And you draw a line that's parallel to that of the upper vertebra, which is part of the curve, the most deformed of the curve. You draw a line there, then you draw a line from the lower vertebra, which is most deformed of that curve, and you find the angle between them. Okay. So kind of moving on into treatment, and this is largely in general type things, but in general, Cobb angles of less than 25 degrees. What was that, Finger?
I want to add something. So
Okay.
Is everybody measuring the same, or is there some type of inter-observer difference?
Yeah, there's a large inter-observer, or not, I wouldn't say large, but it's about 5.
Yeah.
Yeah, so like you can imagine people will kind of like look at their point. Oh, is this the end plate? Or is this the end plate? And they might angle a little bit. Some unscrupulous surgeons will, kind of tilt it to make it more of an angle. Some more scrupulous surgeons will like try to avoid surgery at all costs. But, this is kind of different people will get different numbers, but usually that's about 5 degrees difference. So, for Cobb angles that are less than 25 degrees, usually you just watch them. Even if they're relatively young and have presumably a lot of growth progression left, you just kind of watch it. And you follow them with x-rays, especially if they're going through their growth spurt. You need to watch them a little bit closer, because if you wait, like, everybody here has had a growth spurt, you can potentially grow many, many inches in 1 year's time. And so if you're following them once a year, they might be past that threshold of having like a very severe curve, okay? And in general, curves between 25 and 45 degrees are treated with bracing, and these are skeletally immature patients. And generally, curves that are greater than 45 degrees are treated with surgery, okay? So who gets a brace? So like we mentioned, curves that are between 25 and 40 degrees, and from Risser 0 to Risser 2, okay? If they're a girl, either premenarchal or less than a year postmenarchal, okay? And they recommend at least 16 hours a day to wear, but you need at least 12 hours a day to slow progression. And it's important to remember that bracing does not correct the curve. It only prevents progression of it, okay? And it works. And so, and I stole this from our spine surgeon, Dr. Koshel, but this study, it was a large study, multi-centered, 242 patients, and they were randomized into brace or observation. And 72% of the patients using braces were avoided surgery, and 48% of the no brace group avoided surgery. So there's almost a 25% difference, or is that 20? Yeah, it's 24% difference between progressing to criteria that meet surgical indications. Okay, and so this trial was actually stopped early because they saw such a great difference. But remember that this was patients that wore the brace greater than 18 hours a day, and when I was a kid, I was not going to wear something for 18 hours a day. So that's a very, very big point that you have to make to your patients when you're counseling them about bracing, okay? There's a lot of different types of braces, okay? If you guys, Jeremy and Joe, know the major differences between these, please chime in. This is kind of like the gold standard. It basically puts pressure on everywhere that needs to put pressure on, but it's very large and very cumbersome.
That's the Providence brace.
Yeah, so this is a Providence brace, and remember we mentioned.
This is the Providence.
This is the Providence.
Okay.
And this is a little bit lower profile, and the theory being that if you have a big honking brace, that kids aren't going to wear it, and so this one's a little bit lower profile, and that kids might want to wear it a little bit more, and it suggests that they might get a little bit better compliance. I don't know what this one is, but this one looks very fashionable. I don't know. It's French.
And
Right.
These are really low profile. I was in Pete's clinic today, and we're assessing this girl with scoliosis. She had her shirt on, and I didn't even realize she had a brace underneath her t-shirt. So you can get away with having patients go to school with these on. They're very low profile. So,
So is that what this one is? The Rigo Chanel?
I don't know what that is.
I think the more important talking point is that the real issue for bracing is compliance, and
Right.
it's often, trying to get the patient and the family all on the same team and having buy-in and understanding the importance of wearing it for a majority of the day, 13 hours being a minimum, and some studies showing that 16 is much better than 13. And a lot of patients, if they're very body conscious, even if it is low profile, like Jeremy said, they still won't want to wear it. They don't, because they're around the same kids every day. They might notice, and then they notice there's something different, and then they get called out on that. And the social stigma of that is a very profound mental deterrent. That it's a very interesting thing for an orthopedic surgeon to be treating and trying to kind of reason with adolescents on trying to get them to wear their brace. But it's a real thing. That is the significant force that's fighting you in treating with braces.
Exactly. So again, and this is something that like they'll kind of like ask you about, and something good to keep in mind. Presumably all of you guys want to be orthopedic surgeons, and so you really do need to emphasize that this is the deal. And like Joe said, that you really need to get that 12 to 13 hours a day at the very least, and if not more than that. So big deal. So okay.
Before we move on, Gabriella asked, how expensive is the brace, and is it typically covered by insurance? And the short answer to that is I don't know. The long answer to that is that in almost all states, pediatrics has more insurance coverage than adults. So the large majority, almost every single patient you see has insurance in pediatrics. And if it's indicated appropriately, braces are nearly always covered.
So these are actually pretty, sorry, Joe.
Yeah, no, that's it.
I mean, these are expensive, and it's just kind of like extrapolation because we have a little bit more experience with kind of foot orthoses, and I know that a lot of the foot orthoses that Dr. Lin prescribes are like the AFOs and stuff like that are like $200 or $300. They're like super duper expensive.
An Arizona brace can be close to $1,200. They're astronomical.
Yeah, so you can, and these are right, and these are all custom. So typically with these braces, our pediatric spine surgeon will have he has a rep from the brace company who's with him, and that person will custom fit and custom measure every single person, because every curve needs a special every person needs a special brace because every curve is different. All right. So surgery, posterior fusion is the gold standard. It's for curves that are greater than 45 degrees. It involves doing a posterior export. Yep.
There's still a lot of background noise coming through, and sometimes your voice is fading out a lot. I'm not sure quite what the issue is, but it's sort of in and out.
Okay, how about this?
Yep.
Okay. I wonder if my microphone on my computer is working. Anyway, regardless. Posterior fusion is the thing that you're going to see most for scoliosis. Oh, Jesus. Sorry, hold on. It wasn't my car, but the neighbor's car alarm went off. There's also anterior fusions, which aren't really done in anterior and posterior fusion if the deformity is particularly bad, and there's other deformities that you have to correct for. Those I wouldn't worry about. For med students, those don't really happen. Okay, and so that involves doing a posterior spinal approach, kind of exposing essentially the whole spine. It's a big whack if you guys see on these images. In putting screws into the pedicle. So the screws are big screws, and they go into those straight down to secure that rod. And once those are in, you place the rods to cause the correction to put the correction in. Okay. So this is a very simple slide, but usually it's a midline incision. You can see here they kind of shadowed in the spine. Some surgeons will kind of cheat kind of halfway between like the major curve here. So like if this is the lateral border of the curve, they'll make an incision kind of here. And when they straighten the back out, the resulting line will be straight. Kind of, if you do this, sometimes when you straighten the back out, this will be curved. It's just kind of a cosmetic thing. Okay, and you also have to remember that your dissection is over the spine, and so if it's a significantly large curve, you might have to cheat over so that you can get over the spinous processes. Just kind of a diagram for what you'll see as you're dissecting down. Spine surgery, everybody thinks that is like super duper complicated, but this exposure is actually quite, I don't know, cobby. That's all I've got to say. you kind of go down straight on the spinous processes at midline, and essentially subperiosteally elevate down down the side of the bone and peel off all the spinal muscles into like a large roll, essentially. And you bluntly dissect down. You bluntly dissect and then kind of peel it off with the bovie. And you're down there already. And you need to expose all the way laterally so that you can get access to the pedicles and be able to put your screws down. And these are kind of, so this diagram shows you the differences between the thoracic spine and the lumbar spine where you put your pedicle screws. This is kind of beyond the scope of this, but there are landmarks that we use to kind of generally figure out where we put the screws and we'll be able to get into the pedicle. So on the lumbar spine here, it's kind of the confluence of these lines here. So between the mammillary process here, okay, and the pars, which is here, and the lateral border of the superior articular facet, which is here. Sorry. Oh yeah, it's right here, and the mid-transverse process. And so these lines all come together, and you put your screw there. That's generally where you go. Some people do this blindly, and some people do it under fluoro just to make sure that they're kind of in the barrel of that. Okay. Kind of the same thing for the thoracic spine. You just have to know these landmarks here. It's kind of beyond the scope of this talk. But again, back in the day, people would do this blindly. They'll take a little auger, and they'll make a little incision here and slowly go down and kind of feel the walls. And you'd be able to feel that because the cortices of the pedicles are thicker than the cancellous bone that's kind of in the middle. So when you're going down the middle, it'll be a little bit softer and you'll feel a little bit give. But again, it's kind of a gentle process because you really don't want to cause any damage and you don't want to plunge or anything like that. Okay.
So I think this part is one of the interesting aspects of spinal surgery in general, which is that as the fixation historically has evolved, going from translaminar wiring and hooks to pedicle screws, like Jason's saying, or kind of alluding to, some people will do this quote unquote blindly, and some people using fluoroscopy. And what he's talking about is that like there have been numerous studies looking at the morphology, looking at the size of the pedicles, looking at where they take off. And if you kind of very bluntly just have it memorized the exact location of each pedicle at each level, you can know exactly where the start point needs to be in order to enter into that pedicle and make sure that the screw you're about to insert is going to be intraosseous and not diverting into the spinal canal. So these illustrations are really nice. And that goes in conjunction with that chart that Jason showed earlier of how the different sizes of the pedicles change throughout the spinal column. And knowing the start point is what's going to give you successful entry into the pedicle.
Right. And you'll see with more experience and a lot of, depending on where you're trained as well, but most our spine surgeons they'll look at something, see if it's not quite right, but they'll know which trajectory to generally go. And a lot of the fluoro is confirmation of what they already know.
Yeah, and just as Jason mentioned, you will initially put an awl in to get your starting point and entry, and then you take a ball tip probe and you kind of feel all the walls of your pedicle to make sure you haven't breached out in any of those surfaces. So you feel the anterior, medial, posterior, and lateral surface. And once you confirm that you haven't done that, then you are able to put your screw in. And
I forgot to mention this, and I don't have a slide on this, but it's pretty much standard now that there's neuromonitoring for these cases. For in the case that you do have some sort of wall blowout, or when you're doing your correction, you're putting too much stress on the spinal cord or nerve roots or anything like that. You'll be able to.
What's neuromonitoring?
Yeah, so neuromonitoring is exactly how it sounds, but essentially it's electrodes in the extremities that go in certain nerve distributions, so that you can detect any changes in nerve signals. So either nerve signals going from the head down to the extremities, or from the extremities going down, or a provoked potential caused at the extremities going up to the brain. Okay, so you'll see this intraoperatively when you scrub into these spine cases. They'll ask for the signals, and sometimes you'll see the body jolt, and that would mean that they're sending a signal up from the extremities, and they'll have sensors on the head to see if it's making it all the way up. Okay, and they'll also have a probe that they can feel inside your pedicle holes that you made to see if you have enough resistance between your hole, if there's enough bone between it, or if they're potentially causing some sort of irritation or of the spinal cord. And so you can use with the screws and stuff like that. Okay. Just nothing really special here, just kind of a rough demonstration of like which way the screws go in, and kind of what it looks like when they're all in. Okay, and then so this is the screws are in here already, and after that you put your rods in and fix the deformity. The rods will go in one at a time. Shoot, I don't remember if it's the concave side or the convex side, but a lot of times they'll make our Dr. Kaushal, our spine surgeon, will build in a lot of sagittal kyphosis for the thoracic spine, and then when you put it in, you can turn it to change that axial twist deformity that's part of the scoliosis, as well as making it straighter. Okay, and then you can see that, and then that'll cause it to turn. Usually you don't require like external forces on the body, but sometimes you'll have to push to kind of get it straight. And then this is very important, because this is where neuromonitoring is very important, because if you create too big of a deformity correction, you might have a loss of signals, and then at that point you need to figure out why you lost signals. And so you can either the first step would be to reverse your deformity correction, just to see if that was it, because that would be that would be what you the most recent kind of inflammatory act to the nerves. Okay.
And then also just that central picture is kind of demonstrating a lot of the times to get these corrections, you have to make osteotomies, and there's varying types, but you just have to cut the bone to allow for some more motion. It's just the general principle.
Yep. This is kind of just a before and after of what a post-op scoliosis looks like. You can see that there's a lot of correction there. You can see like more evening out of the waistline here. Shoulders are more symmetric, and there's clearly no obvious curve here. She's pretty straight. The girl. All right. So what's post-op like? These are really large surgeries. Many of the incisions are at least 20 centimeters long, and it's a big surgery straight down the middle of your back. However, contrary to lay understanding, we usually try to have them walk after surgery. Maybe not the day of surgery, but certainly the day after. We encourage them to get up and start moving around. Okay, they'll stay in the hospital for the night of, and a lot of them will get drains because you're doing a lot of bone cutting for the graft. Sorry, I forgot to mention, this is a fusion. So after the correction is made, the vertebrae, the spine will be fused, and you'll essentially have a straight spine, but in all those segments that you instrumented, those will be fused and not be able to move, okay? And so since you're cutting bone and putting screws into the bone, there will be a lot of bleeding. So usually there's gonna be a drain, okay? And we'll stay a day or two for pain control and waiting for bleeding to stop and getting to start eating and things like that. Okay. We allow our kids to, if the healing process is uncomplicated, to return to full activity by 6 months, but everybody's a little bit different, but that's just kind of a general rule of thumb. Okay. Complications that you can have from the surgery are neurologic injury, as we mentioned before. You're working in and around spinal cord and spinal roots. Pseudoarthrosis, which is a lack of fusion, and you get like a kind of a false joint. You get infection. You can get a flat back. Basically, if there's not enough kyphosis built into your construct, you'll be a little bit too flat. And the crankshaft effect, which doesn't really happen anymore, and that happens with mostly like A and P fixation, because there's still continued growth left, and that causes your back to kind of twist. And it doesn't really happen anymore, but it does. Okay. Superior mesenteric artery syndrome is another potential complication. Hardware failure is always a potential complication in orthopedic surgery. Okay, so this is something that I wish I had more of a lead into this, but the Linke classification is essentially the gold standard by which we kind of categorize scoliosis, and this is how surgeons plan which levels they fuse to, and which levels and what they have to do. It takes into account what the curves look like. It takes into account whether or not the curves are correctable, flexible. It takes into account the midline alignment, and it also takes into account sagittal alignment here. So just this is more of a resident thing, but it's good for you guys to know. For the Linke classification, your first step is to assign a curve type, okay? So you have to look at the regional curves, and this is the general breakdown of what the curves are, okay? So you have the proximal thoracic, which is, you have the main thoracic, which ends at the T11, T12 disc. You have the thoracolumbar, which has its apex at the T12 and L1 area, and the lumbar, which is the L1-2 disc to L4, okay? The major curve is the curve with the largest magnitude, and as Jeremy mentioned, you have, did Jeremy say that? I don't remember. But you can have sometimes multiple curves in one scoliotic spine. And so you have the one big one, and then you have the minor ones. And it's important to note whether or not these are structural, and structural meaning that that they're actual curves. And so that's where you get the bending films. So if they correct to less than 25 degrees on a bending film, then it's not structural. If it's still greater than 25 degrees on a bending film, then it is structural. Or if there's greater than 20-degree difference in the sagittal plane. All right. So these are the different curve types. You have the main thoracic curve, you have the double thoracic curve, you have a double major curve, a triple major curve, and thoracolumbar curve, and thoracolumbar and mid-thoracic. So after you have your curve defined, you have to look at your lumbar modifier, and basically you draw this CSVL, which is the central sacral vertical line. It's a line coming from straight up the sacral vertebra, and the modifiers A, B, and C are based on how displaced the ALV, which is the apical lumbar vertebra, which is the lowermost lumbar body that falls outside of your curve. And so if your CSVL crosses between the pedicles, your modifier is A. If it's B, it's just touching. And if it's a C, it's completely out here. So this is the bottom lumbar vertebra of your curve. Okay. And so again, just kind of redemonstrating, you put these together and you get either 1 through 6, A, B, or C. And then your next step is to look at the sagittal modifier. And this is measuring the sagittal Cobb angle of T5 to T12. And you either have a negative, neutral, or normal, or hyper kyphotic spine. Okay, so it's either 10 to 40 degrees, which is normal, less than 10, which is less than normal, and greater than, wait, this should be 40. This should be 40, sorry. And this is how you measure that. All right, so forgot to put a summary slide.
Before we move into the questions, there were a couple of questions coming through the chat.
Sure.
Yazan had asked with this posterior instrumented fusion, what the greatest angle that you can correct is, kind of going with that method.
I think I don't really know. I think the biggest I've seen is like 100.
So what I would say is that there's not a strict answer of how much exactly you can correct, because it's a combination not only of what the absolute curve angle is, and then how stiff that curve is as well. So if you have a curve that has a significant deformity, but it's still relatively flexible, you're gonna have a good shot of correcting it significantly. However, even if you have a curve that's, let's say, only 45 to 50 degrees, but it's significantly stiff, and the way you're going to tell if a curve is stiff, if you remember, Jason mentioned that we get bending films where we have patients laying supine on a table. They have a plate underneath them, and they're bending. They're instructed to try and take their fingertips and try and reach down as close to their ankle as they can get. So they're bending over to the side, trying desperately to reach down towards their ankle, and then shoot an x-ray, and then bend the opposite way and try and bend that way as far as they can. And on those films, you'll see if you had a significantly concave curve, when they bend towards the side of the convexity of the curve, you'll see it bend out some. And in those curves that can bend a significant amount, those will be able to correct a lot. And to the point that some of them, if they're so flexible that they correct to almost normal, in other words, less than 25 degrees is typically the cutoff, then those curves we won't typically even incorporate into the construct, because the underlying assumption is that if a curve is flexible enough to be able to bend under 25 degrees, then it's not actually a real problem. It's actually just a compensatory reaction to the real problem, which is the stiff curve that's either above or below that flexible curve. So I know it's not a very...
Joe, you want to kind of... So I went back up to the slideshow.
Yeah.
And these are all the same patient. So like Joe was talking about, so this curve here, this is the curve here, and there's another
so
curve
straight
here.
supine film, or it could be a standing film, but that's no motion on it. And then if you look all the way over to the right, you have a film with the patient bending towards, so this is a P to A film. It's actually, I don't know whether these are taken supine or standing.
I think they're standing.
Yeah, so the gastric bubble on this side's on the left. So the technologists actually flipped these films. These are P to A, but they look like A to P films.
Yep.
Regardless, you can see that on the first image, second from the right, the patient is bending into the concavity, and then on of the thoracic curve. And you can see what happens on that leftmost film. That patient had a curve in the lumbar spine and a curve in the thoracic spine. And on that film where it looks like the patient is bending, I guess that's towards the left if you look at the cardiac shadow, the patient's bending to the left, the lumbar curve corrects entirely. It's gone. So it's a completely flexible curve. It doesn't really even need to be corrected with instrumentation. And then you look at the one where the patient's bending to the right, and obviously the lumbar spine bends over, but there's no correction of that thoracic spine. So it's a very stiff curve in the thoracic region. It almost doesn't change at all. So you know that you're going to be able to correct that some, but you're not going to promise a patient that you're going to get that back to a straight spine because it didn't seem to even budge on a bending film. And then, so I know that's not a very straightforward answer for you, Yasin, but the reality is it's not very straightforward. So Brian had asked, do you commonly need to expand these fusions later in life due to a loss of disc space above or below? That's a very insightful question. You want to go for that, Jason?
I actually don't know, but I would say usually not. I don't know if you guys know.
Well, so I think what he's driving at is the
Like
possibility of proximal
Yeah.
junctional kyphosis,
Yeah.
Which, so there was, sorry, I'll ignore that. That classification system that Jason brought up, the Lanky classification, is very instrumental in helping us determine how high or how low to go with our fusion. And the purpose of that is to try to prevent proximal junctional kyphosis or any residual deformity being left out of the correction. And there's going to be a higher incidence of proximal junctional kyphosis, meaning that the junctional segment just superior to the last instrumented segment will fall into kyphosis and tip forward. That would be more likely if you were to end your construct at an area of transition of forces. So if you were to end it around T1, T2, then you would know that there would be a possibility of proximal junctional kyphosis. Or if you were to end it right at the apex of the thoracic curvature, because there's a higher lever arm there or a larger moment of inertia. So placing the end of your construct at a strategic place to be in a neutral area of forces will limit the amount of proximal junctional kyphosis. But where we do see that even more often is in adult decompression infusions in the lumbar spine. We see that all the time, that the adjacent segments break down because you're putting a stiff segment in the middle of a flexible spine.
All right, looks like the next one is, wait, sorry.
No, I just wanted to touch on a point what Joe said. Like the thoracic spine is relatively inflexible because of the ribs. So if you do a construct that's pretty much just thoracic, they're still going to have pretty good motion in their lumbar spine, cervical spine. If you have to make your construct larger and go into the lumbar spine, or sometimes we even have to go into the pelvis, that patient's going to lose a lot of normal motion. So if you can get away with not making a huge construct, you're going to be able to preserve more normal function and motion to the patients. But a lot of times, given the curves, you'll have to go into the pelvis. And then, yeah, to answer just the chat question, there was one about special considerations for bone graft material to get that bony fusion that Jason was talking about. And the answer is yes, you use a combination of allograft and autograft. So sometimes when you're doing your dissection, sometimes you can bite out the spinous processes and use that as graft at the end, or anytime you're just taking away pieces to get your starting point on your pedicles, you can use that for graft, and then you'll use some just either cancellous bone chips, or different companies have different type of bone graft that you can use. And you kind of just lay that in from your whole construct kind of at your pedicles, and then close over your muscle over that.
All right. Anything else before we get into the kind of the review questions?
No. Here, Jason, I can do the poll.
Oh, sweet. How'd you know?
All right.
Question one, pretty straightforward. It's more prevalent in males, females, or equal prevalence?
All right, I'm going to end this pretty quickly. You guys are doing great.
All right. So yeah, we mentioned earlier, females, there's a higher predominance in females. In the curves that are around 10, it's 4-1. And in the curves that are between 30 and 40 degrees, sorry, so like the larger curves, the prevalence is, the ratio is about 10-1. So females get this a lot more. Okay. Okay.
And this question specifically, where we do our cutoffs, it's defined by when the patient presents, which you could argue that there's a lot of nuance there. And if a patient presents at 10 years old with a curve, is it really adolescent or not? But
Right.
all of the studies and all of the definitions and everything that we talk about in the literature, so that you're comparing apples to apples, the definition is based on when the patient presents for evaluation.
Okay. So the answer is 1018. And this has nothing to do with like, this is just as defined. That's what they define it as. Okay, question 3. Oh my God. Which of the following, sorry. How do you get off of this? Which of the following patients would be amenable to be treated in a brace? So 14-year-old female with a 50-degree main thoracic curve, 13-year-old male with a 30-degree curve, 16-year-old female with 3 years, that's 3 years status post menarche with 30-degree curve, 11-year-old female with a 20-degree curve. Okay. Ooh. Yeah, so the answer here is the 13-year-old male with a 30-degree curve. It's not the first one because we've already hit that cutoff. So a 50-degree curve is an operative curve. Okay, and a 16-year-old female, 3 years status post menarche. She's already skeletally mature, and I know that's maybe there's still maybe a little bit growth, but generally it's accepted that 2 years after menarche, they're not growing anymore. And in an 11-year-old female with a 20-degree curve, that's still within the observation range, which is 25 degrees or less. Okay. What's the Richter score here? Okay, so this would actually be a 4. And again, we were talking about this earlier. How do you kind of like define it? And it's when it's kind of in between. It's just kind of one person will pick a 3, one person will pick a 4, but you can see that this is going all the way across here, but it's not fused yet. Okay, so that's a 4. Okay. What's the minimum amount of time that a brace needs to be worn to prevent progression or scoliosis? You guys are doing good. 13, it's somewhere within that range. Optimal is at least 16, and if the surgeons could have it their way, everybody would wear their brace all the time, all day long, all night long. Which one of these patients need a MRI? And I forgot to go over this, but levoscoliosis is a left curve, dextroscoliosis is a right curve. Okay. So remember
So-
the typical curve is, go for it, Joe.
Go ahead.
So this is kind of like a trick question. You can't just kind of depend on this, and I apologize for writing a crappy question. But in general, a right-sided curve is your typical curve, and that's what a normal curve is. I'm not giving you guys a lot of information, but for a left-sided curve, that would be an atypical curve, and that would push you to get more of an MRI. And like we mentioned earlier, if you see things like, like a little tuft of hair indicating like a spina bifida occulta, or if it's rapidly progressing, or it's any of those things that we spoke about, you'd want to get an MRI to kind of characterize the spinal cord.
So Jason, can you clarify, for one of the things that confused me early on is, how do you define the side of the curve? Is it the concavity? Is it the convexity? Is it apex? Like, which one is the side of the curve?
It's the it's the convexity of the curve, and so essentially it's like which way it goes.
Right. So think of
Sorry,
it like
Joe. No, keep going.
So think of it like the apex of the curve is pointing towards the side that we will call it, that we will so name it. So a levoscoliosis, or a left-sided curve, the apex or the convexity will be pointing towards the left, and vice versa. And one of the, I don't know if this is proven anatomically, but one of the things that helped me remember that a levoscoliosis is the atypical, is the unusual, and this is a thoracic curve. Levoscoliosis in the thoracic is atypical because if the apex is to the left, that means the concavity is to the right, so there's less space on the right side of the body, and the right side of the thorax houses the liver, which is the largest solid organ. So it's unusual for it to create a smaller space on that side. I have absolutely no idea if that is truly pathoanatomically why that is. It's just how I remember it.
I like to think that left-handed people are weird. Sorry. All right. Question 7. Sorry. So this
just left the chat.
was it?
I said, and 10 people just left the chat.
Wow.
People left you.
No, we only had 33. 1 in 3 people are not left-handed.
All right, take a look at this curve. You have one that's up here that's 42.6. This one's 54.9. Okay. Oh boy. And this is the question. 14-year-old girl. What do you guys want to do?
This is a tricky question.
Ooh, this is a very tricky question.
Yeah.
This is like an ortho boards question. Not that it's hard, but it's tricky.
This is like an attending pimping you in clinic question.
Yeah.
People are doing well, though.
Yep.
All right, send it.
All right. So great. More x-rays, right? So so just in the chat, what do you guys want to get? What x-rays do you guys want to get? Right. Exactly. The benders.
Show me
So you
the
can get-
benders.
Yep. So here's the next question.
So this question is kind of, I think, looking at what people are choosing, is kind of misleading at the angle. I think this is still the patient from before. So
Right.
the curve was higher than what's showing here.
Right. Sorry. Yeah. This is the not bending curves, right? So.
Right,
So let me launch it
So
again.
yep.
Let me launch it again. There we go.
So the reality is the first films tell you what treatment pathway you should head down. But that first question wasn't saying, the first question was saying what's the best next step, which that assumes that you've determined, okay, we're headed towards surgery. So you look at the magnitude of these curves in this patient and you realize this is not a patient, especially with that 55-degree curve in the thoracolumbar region, that's not going to be amenable to bracing. So you've already made your mindset that this patient needs surgery. The next step is get the benders. And then once you have the benders, then you can determine what kind of surgery it's going to be.
When there are two different curves, is there one levo and one dextro, or do you give it one label based on the most proximal one, the largest curve? Based on link classification, it's just where they are. Okay, so we can go back to the, sorry, it might be a little bit faster this way.
It's okay, just go through those images.
Yeah. Sorry, it's kind of defined. Sorry, this is like just very easily searchable. This slide right here, and kind of, and so it doesn't really take into account dextro or levoscoliosis, link classification. It's just and we kind of made a point about the dextro or levoscoliosis with regards to like kind of getting an MRI. If it's like left-sided. And it's one of those things, there's multiple other indications to get an MRI or start thinking about an MRI. It's just because it's not your typical direction of the curve. But with regards to curve and correction.
Direction of the thoracic curve.
Thoracic curve,
A left-sided thoracic curve is very atypical. It's very unusual, and you should consider an MRI. It is actually typical. It is therefore typical to have a left-sided lumbar curve, because that is typically the compensatory curve of a typical right-sided thoracic curve.
Right. But based on linking classification, it's just kind of where it is. So like proximal thoracic, main thoracic, or thoracolumbar / lumbar. And I don't know if that kind of answers your question.
Yeah, and I don't think in general nobody's going to pimp you on a lanky classification as a medical student.
Right.
But you would impress someone a lot if you're in pediatric clinic and you're evaluating a scoliosis patient. If you can measure out those Cobb angles, figure out, you might be off a little bit because sometimes it's a little bit hard the first couple times you do it. You figure out a relative angle for the curve. And then you say, if it's a thoracic curve, is it levo or dextro, and by what degree? So if there's two curves, you say like there's a thoracic dextroscoliosis of 26 degrees with a lumbar levoscoliosis of 20 degrees. And if you just describe it like that, you're going to impress people. You don't have to say this little hunky 3, whatever.
In fact, I would advise that you don't do that. Don't try and offer a lanky classification, because it's very straightforward, but complex. There are multiple layers to it. And if you get one thing wrong, then you presented something wrong. But if you just do as Jeremy said and you describe things and describe it correctly, that's very impressive, and it shows proactivity. And then if you know the linky classification and the attending you're with asks you and says, hey, that was great, do you want to take a guess at what the linky is? Then you offer that. That's how you look like a rock star.
Right. It's a game, guys. Don't blow your load because they always know more than you do. It's true. It's a game. I think that last one was my last question. This is what ended up happening to that girl. And that's all I got. Anything else? Last minute things? Which is advantageous to use hook constructs instead of pedicle. I think when you get like really a lot higher, and those are for a little bit more complex curves, when you have to go into like the cervical spine, sometimes you need to use the hooks when the pedicles aren't very big. I don't exactly know what the indications are. Yeah.
you also use hooks at the top of your, like what Jason said, at the top of your thoracic constructs. A lot of the times after you correct the curve, the shoulder differences are still off. And so you can use hooks to kind of correct those. Ultimately, at the end of the day, you're trying to straighten out the curve, and balancing the shoulders is very difficult. So even if you get a straight spine, the shoulder differences might be off, but using some hooks might help you straighten those out and lessen the difference between the shoulders. Also, over time, even if you end up with a difference in shoulder height, over the next couple of years, the body's going to compensate for the new orientation of the spine, and the shoulder difference may decrease over time.
So Yazan asked about growing devices and how commonly those are used. So that's a great question. This talk was specifically on adolescent idiopathic scoliosis, and typically you're playing this this delicate game where you're trying to, the ideal situation is to wait for a patient to be done growing and then correct their curve. That would be, number one. That if you could achieve that, that would be great. The problem is some patients are progressing too fast, and they're going to get a curve that's too severe too soon for you to be able to then correct it entirely. And you may have to intervene before they are mature and done growing. And so to paint a mild example, if you had a patient who has an idiopathic curve and they're adolescent and they're not done growing, they're like a Risser 1, or if we go to the hand x-rays and get really specific, they're at an age where their peak growth velocity is getting ready to come up, and that they're going to be progressing, but you just want to stall as long as you can and then fuse them once they're done growing. That would be a great indication for bracing the patient and trying to slow down that curve, knowing that you're probably still going to have to operate later, but you're just trying to buy time. Once you get into juvenile idiopathic scoliosis, and we're not talking about congenital, we're not talking about neuromuscular, you've ruled out all the weird things, and you have this kid who's way younger, and they have this crazy curve that you're worried about being so severe that it could compromise their pulmonary function, and you just have to do something. You can't just put them in a brace. They're going to continue to progress. They're going to lose their breathing capacity. That's when these growing rods are just a godsend, because you can put them in. Typically, growing rods will be fixed at the proximal segment and at the distal segment with a few screws, maybe 2 segments in the lumbar spine and 2 segments in the upper thoracic segment, and they're tunneled under the skin and not really fixed to the segments in between, and they're just acting as an internal brace. And typically these growing rods are not actually correcting the curve, it's just stabilizing it where it is. It's more secure than a brace is, and it allows the child to keep growing and preventing the curve from getting worse. And then sometimes, once they're done growing, then you will do a more potent correction with a fusion rod. So how commonly are they used? Depends on where you are. Juvenile idiopathic scoliosis is much less common than adolescent idiopathic scoliosis, so they're not used that often. How long are the cases? Long. Eat something with fat in it before you go in, and also pee before you go in.
Yeah, it also depends on the how bad the curve is. Adolescent idiopathic scoliosis cases are going to be generally a little bit shorter than your neuromuscular, which are going to be usually larger curves, stiffer curves. So you might need to do some more osteotomies, more correction. But like Jason said, 4 to 6 hours is probably a general time. It also takes a while setting up the case. These patients also usually have to get A-lines. They get the neuromonitoring set up. You have to flip them and make sure they're in good position. So all that takes time. Any last questions? Alrighty. Thanks again for joining us. We'll do another lecture next week, same time. I think we might be doing an oncology topic, but we'll let you know. Again, follow our Instagram account, NJMS.orthopaedics, for just information about the lectures, and trying to add some posts about just general orthopedic topics that we see day to day, also trying to tie it into the lectures, and then also we'll get a sense on our resident day-to-day activities and things that we do and see. And then if you guys aren't on the mailing list, just feel free to either reach out to us on the Instagram account, or you can type in your email address here and we'll add you to the email mailing list where you can get access to the slides and also the videos, recordings of the presentations. Yeah.
And I think I speak for everyone when I say that we've really enjoyed this, and we're happy to keep doing it. If you guys know any other students who want to participate, then you can feel free to share the link. I don't think we're not at risk of reaching our Zoom max.